Thank you very much for the kind introduction. Thank you to the chairs, Dr. D.C. Dole and Dr. Shekhar Patil, my dear friends. Certainly it was a pleasant surprise. I think in the first week of January, when I got a call from the Secretary ISMPO that we invite you to deliver the oration on the 29th of January. So certainly it was a huge honor and of course a surprise. So at the outset, I like to express my thanks and gratitude to the chairpersons of this meeting, Dr. Govind Babu and Dr. Sudeep Gupta, and the chairs for the scientific committee and the secretaries. So they asked for a topic. So, I thought, let me narrate my journey in medical oncology over the last nearly 30 years. And I'm sure quite a few know about my journey, but maybe there are certain pleasant surprises here which you are not aware of. And I thought the kind of journey which I've had, since I'm not working in a cancer institute per se, may inspire a few people as to what we are doing and what our endeavor has been. So I thought opportunities are huge. You need to look for them. You need to grab them, provided you are a dedicated and a determined medical oncologist. So I think I'll begin my journey from where I started in oncology. And can I have the next slide, please? So I entered oncology in 1985 after doing my MD medicine from Chandigarh. And that, of course, was the biggest decision of my life because I've kind of stuck on to that and we've gained from that. And let's see how we have contributed to the journey of medical oncology in our country. Next slide. So, in 1985, when I did my MD medicine, I was the topper there. And I said to my friends, to my peers, and to my family that I am interested in oncology. So everybody, dissuaded me at that point in time, just because they said, nobody is going to get cured. What are you going to do? You only have 5FU, you have some platinum. So why are you wanting to join oncology? You can go into gastro, you can go into cardio, and so on. But somehow, I took it as a challenge, and I thought there is a need. Next slide. So at that point in time, as you know, in 1980s, we only had 5 lakh new cases each year. Cancer cervix was much more than breast cancer, and less than 30% patients would be cured, and maybe the data was not there at that point in time in our country. At that time in 85 or so, there was no dedicated cancer institute in Delhi. So there were only general hospitals catering to cancer patients, and there were less than 100 radiotherapy equipments. And there were very few medical oncologists who were only doing medical oncology. It was only a domain of surgeons or radiation oncologists. But of course, a scenario has changed. So that is a decision which, I took at that time in 80s to enter into oncology at the All India Institute of Medical Sciences. Next slide, where Dr. Vinod Pochupille was the head of the department. And she was instrumental in getting me into medical oncology at the Rotary Cancer Hospital. So I had the privilege of being an ICMR Talent Search Scheme scholar because I had cleared their test, and I could actually take any of the subject through the Talent Search Scheme scholar scheme. So initially, as was suggested by my friends and seniors, that it's what are you going to do in medical oncology when patients are going to come in and they're going to die? So and that really happened. And initially, a few months was terrible. And I said, what am I doing with my life? But then, things started to change a little. And at the All India Institute, Professor Vinod Kochupille was working on fetal liver as a source of stem cells, and she was using that for aplastic anemia. And it so happened that in 1986, we all organized under her leadership an international meeting on fetal liver transplants, and several experts came from US, from France, Robert Peter Gale and Richard Champlin and Terrain, and so many people came. And that is the time when we started, at least I started learning about stem cell transplants. And this, led me to write a project on fetal liver transplants in rhesus monkeys. So since monkeys are close to humans, as you know, so we wrote a project and got a grant from ICMR New Delhi. And the next slide. So we did that project on primates, we were so ambitious at that time. We thought, let's try higher doses of TBI to overcome the resistance to the allo transplant, because we thought we'll not be able to do the HLA typing. But as you know, this was a negative study. It had to be a negative study because of the TBI dose was not enough, and the monkeys actually died. So which also contributed to a lot of depression at that point in time, because giving TBI and IV fluids, etc., antibiotics to the primates is a challenge. But I had a team who helped me do this. But that was a turning point in my career. So this was an important learning lesson that helped me understand the HLA typing, the TBI, the conditioning regimen, the immune system, and we did publish the data in transplant proceedings. Next slide. So with this, we then wrote a fellowship for UCLA from NIH, and I got that in 1989. And that's when I started getting training in bone marrow transplants, which we continue to do even today, almost 1 to 2 a month, ever since I joined Sir Gangaram Hospital. So, but more important than that was the beginning of understanding of the molecular biology of cancer. So I spent about 6 months on the transplant team and the wards, but I think almost 1.5 years I was working in the lab, understanding a particular pathway, because John DiPerzio, with whom I worked, was working on platelet-derived growth factors and PAF, etc. And that's where in the lab we started learning the Western blots, the Southern blots, PCR, Sanger sequencing, and and interestingly, with the help of one of our technician, we manually synthesized GCSF, because in 1989 GCSF or GM-CSF was really discovered. So it's a glycopeptide, as you know, having more than 170 amino acids. So we added one amino acid after the other. So it has to be done, without interruption. And day and night, we worked for nearly 72 hours, and we could produce maybe 50 nanograms of GCSF. But that really gave you an insight into the chemistry and the understanding of molecular biology of cancer and in general. Next slide. So then I did have the opportunity of staying back there because they were very keen. But then I said, no, I have to go back to India because of my interests here, and I wanted to serve my country. And when I came back, there's no ICMR cancer institution. So I wasn't keen on AIMS. So I went into medical oncology practice for 7 years. And I gained as a medical oncologist in New Delhi. I did establish a couple of charitable trusts then, which is still standing, Updated Oncology X today. And we did conduct during those 7 to 10 years, several hundreds of cancer detection camps and cancer awareness programs in North India. So that was the time when we really worked on clinics only. And since, as I said, there wasn't any cancer hospital, So we were really going from, 3 or 4 or 5 hospitals to look at cancer patients. Next slide. And then, of course, the final, turning point, or maybe an opportunity which came to me was through Dr. K.C. Mahajan, who was the doyen of surgery in New Delhi and in India. And he insisted that I should come and join Sir Gangaram Hospital as a senior medical oncologist. And that is where I started practicing, 1997 onwards, and I stick on to this place ever since. Next slide. So initially, few years were practiced, but then came the era of drug trials and research, and the understanding which I had, it was time to sort of, deliver that and try to deliver that. But then the ethics committee of the Gangaram Hospital was very scared of doing drug trials, and they actually rejected all proposals from all departments. So, but then I stuck my neck out, and I made them to see reason. And then, of course, they agreed in the end for allowing to conduct drug trials in all the departments. And this then led us to establish the Department of Research, which still stands today. And Professor Ganguly is the chairman now, so who is spearheading the research in all the medical departments. Then, with the Department of Research established, we started registering PhD students, and initially with the Guru Gobind Singh University, and now we have the understanding with Jamia Hamdard and the Manipal University. And this really, initially it was drug trials, but then because of my interest in molecular biology and trying to understand the genomics of cancer, we started enrolling PhD students who started, we started sharing ideas as to what, is available and what we can do. And of course, initially, as I said, it was Southern blots and Sanger sequencing and Western blots. But then with the availability of next generation sequencing, things have become easier. And we sort of started implementing that in our research. Next slide, please. So then we started with these molecular biology projects, and I'll share a few of them with you in the next few minutes. So it so happens Dr. Shekhar Patil is the first collaborator whom we had initially, and he's the chairperson today for the oration. And I requested him that let's do a study comparing the EGFR mutation in North Indians versus South Indians, and it's very readily agreed. And to our surprise, we did find a difference of incidence of EGFR mutation in North versus South Indian, and the p-value was significant, and the data was published in the Journal of Cancer Therapeutic Research. So that was the initial beginning in 2013-14. Next slide. So then, of course, we started having our PhD students, and Sachin Minhas started or wanted to look at the polymorphisms in the CYP2C8, and this has been related to inactivation of drugs like paclitaxel, and he started to look at breast cancer. Next slide. As to what is the incidence of this mutation in the North Indian population and in patients with breast cancer. Next. And he did find subtle differences between North Indians. You can see 4%, and South Indians and the other different populations have a lower incidence of these mutations. However, he did not find any correlation with this mutation vis-a-vis the pathogenesis of breast cancer. He studied 251 patients, a large number, but maybe the numbers were small. Next slide. And of course, this data was published, in the Genetics of Molecular Research. So the CYP, 2C8 is higher, but then the correlation between the breast cancer is not there. Similarly, next slide. He also looked at the CTLA4 and this particular, polymorphism and association with breast cancer risk. And he again studied those 250 patients. Next slide. So I'll skip this. Next slide, please. to show again there wasn't any correlation between the this particular polymorphism and the breast cancer risk. So as you can see, the p-values are not significant. So you did start with these kind of negative, but then a lot of work was done because they nearly studied 250 normal people, normal women, and 250 patients. Next slide. So then we had Yogender Shopin, who wanted to work on the TGF beta pathway in CML. Next slide. So the idea is to work at different levels to identify the molecular pathogenesis of malignancies. And next slide. So he wanted to again look at, he did the NGS studies for these, and the next slide will share that data, the sequencing data. And as you can see, he did find mutations in various pathways of these SMAD 2, 3, 4, 6, 7, and the TGFR genes. Next slide. So I think these are I'm not going to go to the details of this. Next slide, please. So there were pathogenic variations, and he did conclude, he did the work in nearly 50 cases, but then the idea is to expand this work further to understand much more work. Next slide. Next slide, please. And then came Dr. Mayank Johari, and we were looking for new mutations in BCR-ABL, and we did find one. Next slide. Upfront, untreated. Next slide. So we saw this particular, heterozygous variation in the ABL-SUN gene, which, is possibly pathogenic and does cause CML. Next slide. So Mayank continued with us, and then he developed a major project on colorectal cancer, in which he studied nearly 100 patients of colorectal cancer with various NGS technique. As you can see, 48 gene cancer panel. Next. And he could find, as you know, cancers are not driven by and large by a single gene, and you can see it very clearly here. That the several genes, including KRAS, BRAF, PIK3C, PTEN, NRAS, APC, and P53, and so many others are mutated in the same patient. So that is, something which has been baffling all of us. And in terms of the therapeutic targets, so if there are multiple genes which are affected in a given cancer patients, how do we address that? And that has been the whole scenario for cancer, because it evolves so very slowly, and so many genes get involved and get altered. So these were various, the KRAS mutations seen by us. Next slide. BRAF, and the next slide, please, and the PIK3CA. So there's this data has been published in 3 journals. Next slide. So he did extensive work on colorectal cancer. The microRNA work he could not complete, but he did some basic work there, and made us understand the role of microRNA in colorectal cancer. Next slide. So that is something which he also did, but then we could not complete this work. Next slide. So since we were on solid tumors and on GI, and the gist is, since we are at our hospital, we do have a fair number of GI cancers, including GIST. So we did this project on nearly 35 cases. Next slide. And this we published very recently in 2019. Next. And in addition to, c-KIT, which was the most common gene, we did report KRAS, TP53, AKT1, ERB2, and PIK3C gene mutations. So this, again, work was done through next generation sequencing. So since we also have interest in hematology, so a couple of papers we did publish on myelodysplastic syndrome on multiparametric flow cytometry. So we have a good hematology lab who are doing the flow cytometry, virtually even 8 color they are doing for myeloma. And this is, next slide, please. So I think this was on MDS, and they did, have this OGATA score to correctly diagnose in almost 80% of the cases. Next slide. So I think I shared with you the basic research which we've done so far, and published nearly 10 to 15 papers in that direction since 2013. Next slide. So the ongoing projects. So unfortunately, COVID has really, put its, shovel in the way, just because, people are not coming, patients are not coming, the labs are closed, and even the researchers are getting affected. So this is one of our, pilot project in terms of identification of biomarkers to monitor responses to immune checkpoint therapy in cancer patients. So this work we started nearly 3 years ago, and Kriti is the person who is doing this work. And this is a really a showcase kind of a project which we have, and we are really looking forward to the data which we are accumulating. Next slide. So I think the idea is very clear: to collect the blood samples from patients who are being treated with immune checkpoint inhibitors before, after, and correlate the data with the responses, whether a patient has a complete, partial, stable, or no response. So we have almost 50 patients. I mean, this is an old slide. I think we already have 70 odd patients at this point in time. Next slide. So this is work in progress. And the idea is to do multi-color flow cytometry, which Kriti does it herself. She has a separate flow cytometer, and I'll just show you some data to that effect. We're also doing the NGS, tumor mutation burden, PDL1 testing. And Dr. Ganguly, who is the chairman of the research department, pushes his students to do as much as possible. And they are also looking at metabolomics, they're looking at proteomics, and they're looking at microbiome. So I'll just show a little bit of that. We don't have a lot of data, but then let me share the. So I wanted to highlight that, we in Delhi itself, we have all these facilities, maybe not at Sir Gangaram Hospital, but you have to tie up and collaborate with others to perform this work and this activity. Next slide. So this is some of the data. You can see the CD8 cells, which are the cytotoxic T cells. So in patients who are responding, so there is an increase, which is P value is 0.008. And you go further, next slide. The PD1 and the Ki67 positive cells, CD8 cytotoxic, they go up significantly. So PD1 and the Ki67 immune cells. So this is a study on immune cells. This is immune profiling. So which is post-treatment, trying to differentiate between responders and non-responders. Next slide. So you can see CD80 mature, dendritic cells. And so I think she has a huge flow cytometer in which she can pick up nearly 40 kinds of cells. And this is the data which, this is very early data. And early in the sense that they're doing even much better flow cytometry to look at various types of immune cells. Next slide. So you can see these mature dendritic cells, going down in patients who are responders. Next slide. So these are the different kinds of myeloid cells, which are, increasing after treatment. These are the myeloid-derived stem cells. So actually you need to go into the depth of each type of cell and what is the correlation between the response and how do they behave in responders versus non-responders. So a lot of data available now. So this is a summary slide for responders, where you can see that the CD80 cells go up, and the mature dendritic cells, they go down. And if you look at the T cell co-stimulation goes up, Tregs go down, and T cells virtually remain the same. So we're just very eagerly waiting for this data to get finished, and so that we have some understanding in depth on the immune response to immune checkpoint inhibitors. Next slide. So this is metabolomics, which is a recent entry into my dictionary. So these are metabolites, which are small molecular substrates, intermediates, and products of cell metabolism. So you can see here genomics, transcriptomics, proteomics, and then metabolomics. Next slide. So they are trying to look at these 50 samples by doing the mass spectrophotometry. And this kind of work is being done at the ILBS in Dr. Sareen's lab. And I think we are looking forward to this data. Next slide. So I think they already found a couple of pathways which may be altered. linoleic pathway or primary bile acid biosynthesis. They require further studies. This is work in progress. Next slide. So I think folate biosynthesis, arachidonic acid metabolism, and ascorbate and alderate metabolism. So I think they are just analyzing this data. Maybe in the next 2 months, we wish to sort of complete this work. Next slide. Of course, PDL1, as we all know, and then there's a correlation there. Next slide. You can see that this is the positive slide. Next slide. And that the PDL1 expression does correlate with the response, which is quite expected. Next slide. So this is again, as I said, work in progress. Next. So beyond metabolome, they also want to do the cytokine analysis. I think which is another 20 cytokines which they will be studying. I think the samples are already there. Actually, in the lab, they're working at the THSTI. They've closed the lab because a lot of people got infected with COVID. So COVID has really come in, in a way to sort of interrupt our working. Next slide. So we are looking at proteomics as well, because very recently Dr. Ganguly was very keen. So since we're talking of COVID, all of us have been affected by COVID, and initially WHO and all said COVID is not airborne. But then I was convinced, and we gave the ventilation theory, which we published in 2020, that high viral load and poor ventilation is the cause of high mortality. And then we also got together with this idea that the number of air exchanges in the air conditioning unit should be increased. Normally people do 5 to 10 exchanges an hour. We thought it should be 12 to 14 at least, so as to dilute the air, which is coming from the room before it is recirculated into the room. So then we are doing currently a project where Kriti is involved. We are treating the air in the air handling unit and the air conditioning filters with UV rays to get rid of the COVID. So this results, I think we might have in the next couple of months, because we got diverted because there was no work going on the oncology. So this is something which we're trying to contribute to COVID. Next slide. So my wish list is to improve the understanding of various cancers at molecular level, which you could see and which you will see further when I talk about my future projects, which we are in the pipeline and which you're already working on. One thing which I've been very keen on and trying to, why are we missing on clinical work? Why are we missing on clinical data representation? Just because our institutions, even big institutions, private or otherwise, are not digitized, neither the outdoor nor the indoors. So I think we must make an effort, convince the admins, convince the owners of the institutions to digitize the data from outdoor or indoor, so that we are able to, and that is how the Americans and the Westerns are able to reproduce the data so effectively. Our problem is we do it manually through our medical record sections, and then we miss out on so many cases called loss to follow-up. The credibility of the data is gone. So I think that now that we are in the era of digitization, it is time that the institutions look into this very, very seriously. So some of the clinical work or research which I have done or published, I'll just show you this South Asian Journal of Cancer. And then, of course, we did some work on lung cancer, on breast cancer, and we had this, docetaxel, oxali, and capecitabine on gastroesophageal cancers. In myeloma, we did publish, bortezomib, dexamethasone in newly diagnosed. So, and we've been part of several pharma trials and registries. Next slide. So now a few minutes on the ongoing projects, which actually, we have already got the ethics approval, and we have sent the samples. So we chose 4 cancers, where we wanted to look at genomics and the MSI and the PDL1 testing. So we already have data almost on 40 odd cases of these 4 kinds of cases, which we just got the results. So we are in the process of analyzing this. So we did it with the 4 base care team. Then, of course, 2 years back, the ctDNA and its role in metastatic cancers before and after chemotherapy and to correlate with the response. We started this study. We already enrolled about 15 cases, but then all this went, haywire because of COVID. We have data on 15 patients. We will perhaps, share. Maybe I want to add on to more work. So I think a few weeks back, I did say this, that non-Hodgkin's lymphoma is a neglected area for NGS in our country. There's very little data. So I think Kriti and they have got a project on. We are just going to submit it for ethics, and we are keen to at least analyze 100 patients of non-Hodgkin's lymphoma. Next slide. So I think Rajiv Gandhi and the Tata are working with Dr. Shantanu for this multi-center breast cancer genomic project. And they've approached us, and we might sort of contribute to this particular study from Dr. Shantanu at the IGIB. Okay, so these are a couple of new thoughts which we've been exploring now because we have a researcher with us in the Department of Research who's very good at proteomics. So we thought, let's see what are the signature differences between smokers and non-smokers. So we are, developing this project. And similarly, as I said, Kriti has a huge handle on flow cytometry. And I think the cancer stem cell detection before and after curative surgery or curative treatment could be a viable project, which I'm very keen on thinking about. Next slide. So just a few more slides, 2 or 3 more slides before I end. 97, we started organizing national and international workshops, and we've already organized 21 such conferences. And 4 years ago, we did a consensus conference on breast cancer, which I was just talking about. And Purvish Parikh, we invited as a co-editor, and we published the work in the South Asian Journal of Cancer, which I'll just show you. The similar conference we organized with the Christie's Hospital, Manchester, UK, 2 years back on colorectal cancer. Again, Purvish Parikh is instrumental in bringing out another booklet. Next slide. So this was the journal which Purvish Parikh, helped us bring out on breast cancer as a silver jubilee issue in 2018. Next slide. So I think that was all in terms of my work or my journey. And I just have to say that you really have to grab upon opportunities as they come to you, which is what I did, as you saw in the journey. So before I end, 3 more slides. I want to thank the collaborators, Sachin, Kriti, Mayank, Yogender, and we have another Yogender today with us, Dr. Madhusudan, Dr. Srinivas, and Manpreet, who really been instrumental in getting all this put together. We have a very robust genetics department and, of course, research department. Professor Ganguly and his team, Dr. I.C. Verma from genetics and his team. Pathology department regularly helps us. And now, as I said, we are collaborating with the Faridabad lab, the ILBS, and the Jamia Hamdard University. So Dr. Rana is the chairman of our hospital, and he is very interested in research along with the ethics team. So I'll be failing in my duty if I don't thank my wife, my children, parents, and of course, my dear friends who are listening here as well, who really helped me, stood with me, and stimulated me to work and produce this kind of work. So 2 slides in the end, which are not medical. I'll just, next slide. So I'll just, these couplets I'll share with you. असफलता एक चुनौती है, इसे स्वीकार करो. क्या कमी रह गई देखो और सुधार करो. जब तक न सफल हो नींद चैन को त्यागो तुम. संघर्ष का मैदान छोड़कर मत भागो तुम. कुछ किए बिना ही जाए जय जयकार नहीं होती. कोशिश करने वालों की कभी हार नहीं होती. This was said by Harivansh Rai Bachchan. I think it is very, very true for a medical oncologist who really, or an oncologist for that matter, or a researcher who has to face a lot of criticism, a lot of negativism. But then if you keep working, you are going to be a success. And the last slide is my, prayer. And this is a song actually, which is written by Shakil Badayuni. and Naushad ji has given the music, and Muhammad Rafi has, and this is the composition of our country. मन तड़पत हरि दर्शन को आज, बिन गुरु ज्ञान कहाँ से पाऊं, दीजो दान तो हरि गुण गाऊं. This is a prayer which I've been doing. This is a song. It's a very difficult song. Well, I've been trying. You may hear this 2-3 months down the line. So I think with this, in the field of medical oncology, I have gained a lot in terms of my journey in life. And I pass on this journey to you guys to take some positive feedback and, be compassionate with your patients. Be, the practice is different from research, but then getting in or dwelling into it is something which is required to give the best out of you. So thank you very much, ISMPO. Thank you, Dr. Smruti. I think she called me. And thank you, Govind, and thank you, Sudeep, and thank you all members of ISMPO for giving me this opportunity. Thank you very much.